Good evening, everyone. I wish to thank Dr. Arup Chakraborty and AIOS for giving me an opportunity to be a part of this very key webinar. And I'll be speaking on corneal topography and tomography for IOL power calculation. So, as we know, corneal topography is a two-dimensional study of the curvature of the anterior corneal surface, and the devices we use for topography are usually placebo-disc-based. While corneal tomography is a three-dimensional study of elevations of the anterior and posterior corneal surface, and being three-dimensional, it also gives us an ability to measure the thickness of the cornea. The most common devices we have for corneal tomography are OBSCAN, which is scanning slit beam device, and the slime pack devices like Pentacam, Sirius, and Galilei. The placebo-based corneal topography use multiple concentric rings which are projected on the cornea, and the image is reflected from the tear interface. The edges of the ring, the light and dark rings, are detected, and their distances from each other are analyzed. And the smaller the distance between the edges, the steeper that portion of the corneal surface. While for the elevation-based corneal tomography, the elevation is measured from a reference surface, and this reference sphere is generated on a particular eye and is unique to that eye. And the reference sphere may vary from one eye to the other. So what are the roles of topography and tomography in IOL power calculation? The most important is probably screening of patients for premium lifestyle IOLs. We can plan incisions to control pre-existing or induced astigmatisms. We can assess spherical aberration for choosing aspheric IOLs. We can assess posterior corneal astigmatism, and we can also measure corneal power under certain difficult conditions. Screening irregular corneas. We know that any refractive correction, be it spectacle glasses, contact lenses, or IOLs, it can only correct regular astigmatism. It cannot correct irregular astigmatisms. And aberrations induced by diffractive optics of multifocal IOL can worsen existing aberrations in an irregular cornea. So we have to know which are the normal topography patterns in which patients we can use these lifestyle IOLs. So among these standard patterns described by Rabinowitz, the round oval and the symmetric bow tie are considered to be normal pattern, and they have a round oval or a symmetric bow tie regular astigmatism. Coming to the second use of tomography, topography in IOL power calculation or biometry or achieving emmetropia, we can use it for incisions like tanning to reduce pre-existing corneal astigmatism. And this incision can be clear corneal incisions, which can be single or paired, can be limbal relaxing incisions, or they can be astigmatic keratotomy or AK incisions. Determining spherical aberration and correcting for spherical aberration is a bit complicated. We know that the average corneal spherical aberration, or SA as it is called, is plus 0.27 microns with a standard deviation quite large, 0.1 micron. And the effect comes into play when the pupil is a little big, more than 4 millimeter. That is in the mesophic or a scotopic situation. Here, because of the spherical aberration, if the spherical aberration is high, there will be decrease in contrast sensitivity. And this spherical aberration, and so do other wavefront changes, derive largely from the anterior corneal surface. And this corneal spherical aberration can be calculated from a Q value, which is generated by most topography and tomography machines, and keratometry values. This is only one option for measuring corneal spherical aberration. We can also use wavefront aberrometers for measuring corneal spherical aberration, or the spherical aberration of the entire eye. Q values measure corneal asphericity, and from there, and the keratometry values, there are mathematical formulae from where we can measure corneal spherical aberration. And the normal values of Q, which measure the corneal asphericity, range from -2 microns to -4.5 microns. Now, what we know is these aspheric IOLs can be used to neutralize positive spherical aberration of the cornea to increase contrast sensitivity, as I have said, particularly in a mesopic condition. And different aspheric IOLs have different spherical aberrations, and they can be actually chosen under particular situations. So the IQ IOL from Alcon has a negative spherical aberration of 0.2 microns, Technis has 0.27, and the Envista series from BNL is said to be a neutral aspheric IOL without any spherical aberration of itself. So when the image quality is critical, that is, we need a very high contrast sensitivity, we should use a negative spherical aberration IOL to negate the positive corneal spherical aberration. Whereas when the depth of field is critical, we might plan to keep some spherical aberration residual. So we may use a neutral spherical aberration IOL or a non-aspheric IOL. If there is a likelihood of IOL disintegration, it's better we do not use a negative spherical aberration aspheric IOL. We should use a neutral spherical aberration aspheric IOL. After a keratorefractive procedure, the spherical aberration changes. In myopic correct, if there is a myopic correction with the of the corneal refractive correction, there is an increase in the spherical aberration, and in a subsequent cataract development and a post-LASIK cataract situation, we should use a negative spherical aberration IOL. Whereas for a hyperopic correction in the LASIK correction, there is a decrease in the spherical aberration, and we should use a neutral spherical aberration or a non-aspheric IOL. We can also fine-tune IOL power based on assay. We can judge preoperatively the expected residual assay according to the IOL we are using. And if the expected residual spherical aberration is 0, the target refraction should be plano. If it is positive, then the target refraction should be reduced by 0.25 diopter for every residual spherical aberration of 0.10 micron. And if it is negative, then refractive aberration, the target refraction should be increased in steps of 0.25 diopter sphere for every 0.1 micron spherical aberration. Coming to posterior corneal astigmatism, the posterior corneal surface is steeper in the horizontal meridian, and thus being concave, the effect on the total refractive power of the cornea is the reverse. Thus, it contributes to the or adds to the against the rule astigmatism. It has been seen that with higher degrees of anterior with the rule astigmatism, contribution of the posterior corneal ATR is higher, and corneal tomographers have the potential to give us the relevant information for the posterior cornea. Coming to determining corneal power for IOL power calculation, as a rule, corneal topographers should not be used to derive the K value for IOL power calculation. The nearest correlate to manual keratometry values, which are still considered to be the gold standard for IOL power calculation, are the SIM-K values on the topographer or the tomographer. However, in certain situations, corneal topographers do help us in obtaining the K value for IOL power calculation. Like in this specific situation is following a keratorefractive surgery. So if it's a post-RK situation, we can use the numerical view of the Atlas device from Zeiss, and we take the K value as the average of the foldings. Whereas in the post-LASIK situation, particularly post-myopic LASIK, we can use the EKR, the equivalent K reading, and this is used with the Holiday 2 or another third generation formula with double K correction. So what are the take-home messages? The manual keratometry is the gold standard for K value for routine IOL power calculation. Corneal tomography helps us in detecting and excluding irregular corneas when lifestyle IOLs, the presbyopia correcting IOLs are being considered. Corneal tomography may help us to plan incisions to reduce astigmatism, and corneal topography or tomography may help us in correcting for posterior corneal astigmatism. Thank you for your patient hearing.